Hi and welcome everyone to Malaysian Congress of Geriatric Medicine 2021. Hopefully we are all still fresh as this is our first day. For today Breakout 2 session, I will be your chairperson. My name is Dr. Nurul Huda. I am a final year geriatric fellow currently based in Hospital Kuala Lumpur. Our main topic today is age gracefully and building resilience. We are very fortunate today to have three esteemed speakers to discuss on this topic in detail. Our first speaker with her topic on mental health in community is Associate Professor Rangisman Sontorchaya from Faculty of Nursing Thammasat University. She has taught psychiatric mental nursing health to both the undergraduate and graduate level, and she is assigned as a committee of an international doctoral nursing program. Her research specialty is caring for all the adults with depression and qualitative research. In 2019, she received the Fulbright Scholarship Visiting Scholar to exchange her teaching and research experience in nursing at Florida Atlantic University. She is also actively involved with voluntary work and as a member of the Thai Psychiatric Nursing Association and served as a committee of the editorial board of the Journal of Psychiatric Nursing and Mental Health in Thailand. Our second speaker is Associate Professor Dr. Davinder Kaur Ajit Singh. She will talk on the topic of reversing frailty in the community. She is a senior lecturer at physiotherapy program and the chair of the Center for Healthy Aging and Wellness from Faculty of Health Science, University Kebangsaan Malaysia. Prior to joining UKM in 2005, she was a practicing physiotherapist with Ministry of Health. She was graduated from University of Brighton, United Kingdom in 2009. Her primary research interest is in geriatric physiotherapy, spine and aging and analysis of function. She had extensive research on fall risk assessment in older person and is a leader in geriatric physiotherapy research in Malaysia. Her current ongoing projects include falls, cognitive frailty and mobility among older person. And for our last speaker for this Breakout 2 session is Associate Professor Dr. Asrini binti Abdul Razak, who will be talk on COVID-19 and social isolation. She is a senior lecturer and consultant psychiatrist from University Science Malaysia. She completed her master in psychiatry from the same university in 2005, and in 2015 she completed her PhD in social psychiatry from Monash University, Australia. Dr. Asrini is currently the Deputy Chairman, Brain and Behaviour Cluster from School of Medicine, Medical Science USM and Coordinator for Psychological First Aid Team for COVID-19 in Hospital USM. Her main work is on age psychiatry with special interest in social and women mental health. She has secured grants and published manuscripts in these subjects. She is also actively involved in NGOs, currently as the Vice President of Persatuan Terapi Psikospiritual Malaysia, Advisor for Persatuan Perubatan Psikologi Kelantan, and had initiated Kelantan's Carer Support Group for Dementia. I really hope everyone will enjoy the session today. Before we start, few housekeeping notes. Any question can be submitted in the Q&A chat or chat box. So with that, I would like to welcome our first speaker. Thank you.
Hello everyone, it's great honor and pleasure to share my presentation with you today. And I would like to thank you the Malaysian Congress of Geriatric Medicine invite me to talk about community mental health in mental health. And my topic for today is depression and resilience in older adults during COVID-19 pandemic. So as you know, today people in the world have impact from the coronavirus, especially the global health. So in the present, it can be said that we are in the fourth wave of coronavirus pandemic. what does it mean? So it means that we live with the coronavirus for a longer period of time, and people will get sick and they die. And the long period of coronavirus made many people got stressed, anxiety, hopeless, despair, and finally suicide action. So when you look at in the United States and the China, so we found that the psychological impact during the COVID-19 in the United States is 16.1 reported anxiety disorder and 14.4% depressive disorder, whereas in the China is quite a bit higher. So they report 62% depressive disorder and 52.4% is anxiety symptoms. And when you look at Thailand, we have the impact of coronavirus also. We have the 57.2% feeling worries, 47.3% loss of appetite, and 25% loneliness, and 23% they have unhappiness. So in the mental health that we focus on depression in the older adults that they experience about the COVID-19. The symptom of depression include worry, insomnia, loneliness, sadness, boredom, and social isolation, which is quite a bit different from the depression when the people doesn't get the coronavirus. And the cause of depression during this time include chronic medical illness, for example, hypertension and diabetes. And they feel, look at their self-perception of poor health. And because of they have a limitation in the everyday life, so the functional impairment and cognitive decline can cause depression. Also, the maladaptive coping, and lastly, the negative emotion will cause also. And for the apply of the mental health intervention during the COVID-19, the consideration from the Pan-American Health Organization and WHO, they recommend the fourth level of the mental health intervention. The first level is promote mental health needs, safety, information. For the second level is about family community support. That this means that they support from the vulnerable people. And the third level is a non-specialized support. So this kind of support is from the healthcare volunteer and people in the community also. For the mental health service, this level is more about people who get sick, for example, psychiatric illness, and people who vulnerable group. Okay. For the in Thailand, we apply about the mental health support that provide the basic needs of health and like knowledge about the protection and hygiene of the coronavirus, and the information about the COVID-19 protection, such as wash your hands frequently and long distance, and have some wear the mask all the time. And in family and community psychosocial strategies, using remote communication and maybe about the telehealth. And we have the health service line, for example, helpline, we call the helpline. So in the helpline, we provide the counseling, and the number of the helpline is 1323. And we found that during the February, we use 20 and 30 lines. But in March, the high rate of the counseling line includes 600 lines. And in the middle of April, it's about 315 lines. And these counseling lines, we found that 51.8% stress and anxiety, and 37.99 is psychotic cases, and 6.57% they ask about any information. So this from the Thai Department of Mental Health. For the goals of mental health care in Thailand, we have two goals. First is equity, that in access to mental health care for all people, because we have the outreach assessment by healthcare volunteers, that this is a very strong healthcare volunteer to help healthcare providers in community. They walk in and they knock the door to people in the village and use a telephone call to access mental health problems. And they have some application mental health check-up that maybe we call this application may be called like Sabai Jai and Suk Jai to check up about the mental health assessment. And mental health assessment online and application for stress, depression, dementia, happiness, resilience, and emotion. And the second goal for the mental health care is to increase the family and community potentials of mental health care. So building the safety, we use the component of building safety by provide the knowledge and practice about self-restrict hygiene. And for promoting peaceful mind and careful about news and information. And the other thing, we have hope. So instill hopeful and good plan about the vaccination. And lastly, we provide the stigmatization of people who get COVID-19 infection. We take care for each other. So we don't label people who get infection. So this slide, I show that Dr. Yongyut Wongpiromsan, he developed the mental vaccine project. So they use 4 components of safety: peaceful mind, instilling hope, and destigmatization by using the strategy about the connectedness and effectiveness. And the other thing is a psychosocial intervention for older adults to monitor the consequence of isolation and provide mental health intervention. And usually we use a psychological first aid around the world. And we provide online or telephone support for social networks and peer support of community outreach and reminiscent intervention, the mental health promotion program, and the behavioral activation program. So I will show you about the behavioral activation program. So this program is focused on any action that in a small group that leads to the positive reinforcement. So any activity that show positive reinforcement, so we apply that for the older adult. And when we compare to the control group, so the outcome is quite good because we can decrease the depressive symptom significantly. And another program is a mental health promotion program. So this program focuses on the we call the positive psychology, that we focus on about the relationships among the group members, and we let them engagement and very satisfaction in the activities, and they have show the positive emotion like happiness and satisfaction, and they know about the meaning of life, and then they can achievement of the thing that they can done. So this program make them decrease depression also, that when I compare to the control group. So the statistics said that this can decrease statistics significantly statistic. Okay, so for resilient in older adults, because this older adult among the COVID-19 pandemic, they experience about adversity. So the adversity for the older adult includes the arranging for the essential medicine. So they need to give the medicine, but they cannot go to the hospital. They cannot access to the hospital. So we transport the service to the hospital. Some people have difficult to get to the hospital and limit about the number of the patient to the hospital. And they have difficulty in the managing the household chore and arranging for food and other things. And this can be psychological distress to be the difficulty time during the COVID-19. So for the resilient intervention for the people who have physical decline or chronic illness, we can provide health knowledge, self-prevention, wash hands, and reduce spread of disease, and COVID prevention about healthy eating, regular exercise, positive mental outlook, adequate rest, and social distancing. Another resilient intervention can be for the psychological distress, because Thai culture and Buddhist aspect believe that if we do the good thing, and the good thing will come to you. For example, if you can protect yourself from the coronavirus by practice about washing hands, wear the mask all the time, and keep distance at least 2 meters. So you can protect yourself from the COVID-19. And about the mental vaccination that I stated earlier about the project of mental vaccination. So this kind of to give them strength about the provide or listen to the news very careful, and they have some calm down and some consciousness when they listen or watch the TV or television. And community potential utilization. We use a lot of organizations, for example, healthcare volunteers, the community leaders, to give them the knowledge and practice. And the last thing is a positive relation and communication, because we use a positive relation from the healthcare providers and family and friend network that can provide and talk about to the older adults. Use maybe telephone line, telephone call, and maybe the any online or media. So this can be the positive communication. And 5 steps of the building up of resilience. The first, we let them understand about the situation that COVID-19 is a type of the virus that can spread disease, and finding things to hold on, because they can believe that we have the campaign about we fight together and we survive together, and we need to let them do about the open-minded positive emotion, so they can have the open-minded and consciousness, also the mindfulness, and learn to relax yourself. So that's why the older adult can do something like a meditation, and maybe do any activity, singing, or maybe playing games that they can relax. So for the resilient intervention, we provide media that the people in the community can use, especially the older adults. So we provide several medias. For example, this media can let them have a strengthen in the daily life. They have a 5 step of resilient intervention. And the other thing is about the knowledge. We provide the knowledge of the coronavirus pandemics and its protection. And then another slide, another video is about the people who can get together and can take care of each other. So let's see example of the resilient intervention here. First step is about the understanding. Second is hold on your mind. Third one is about the relaxation and mindfulness. Fourth is open-minded, positive emotion. The last thing is about healthy eating, exercise, and sleep well. For the last slide, so regarding to the Thai culture, older adults are the population who receive the best care from the healthcare providers, family members, and people in the community. So psychosocial intervention can decrease the depression and enhance the resilience among older adults during COVID-19 pandemic. And resilience as a process needs social coping resources that reflect Thai belief about elder respect and healthcare focuses. Consequently, several effective strategies of social coping resources strengthen the psychological and community resilience. And hope you enjoy the presentation. Thank you very much for listening patiently and attentively. Thank you.
Hello, greetings. Allow me to share my presentation entitled Reversing Physical Frailty Within the Community. The world's population is aging and Malaysia will attain aged nation status by year 2030 when 15% of its population will be older persons. And with this, we are heading to increased lifespan, increased prevalence of chronic diseases, physical disability and impairments, and also other comorbidities. Over the past few years, frailty, one of the four giants of geriatric, have attracted a lot of attention, mainly because of its association with adverse health outcomes in older persons, some of which includes increased mortality, increased morbidity, increased depression, increased disability, increased number of falls and hospitalization, and decreased quality of life in older persons. Recently, a few subtypes of frailty syndrome have been identified, which includes physical frailty, cognitive frailty, psychological frailty, and social frailty. Generally, it is a combination of physical frailty with other domains, which is cognitive impairment, psychological, and social dysfunctions. So what is frailty? Physical frailty refers to a distinctive aging-related health status in which multiple body systems gradually lose its innate capacity, resulting in decreased physiological reserves and resilience in the face of stressors. Accordingly, an important understanding about frailty is that as with chronic diseases, the focus should be on functionality and not diagnosis of the disease. The global prevalence of physical frailty among community-dwelling older persons is approximately 11%. The prevalence of frailty among community-dwelling older Malaysians is about 9%. However, please note that pre-frailty is substantially high and is about 62%. This is the group that will benefit from community-based setting programs. Frailty is a multidimensional syndrome and its onset of manifest in hierarchical orders, developing weakness, followed by slowness, low physical activity, exhaustion, and weight loss. We must understand that physical frailty involves multiple systems, and older persons with frailty will usually have several comorbidities. However, frailty is a dynamic state and we are able to assist to reverse it. For this, intervention is mandatory to prevent adverse health outcomes in older persons. Knowing the physical frailty risk factors can assist us to target intervention for high-risk groups, and some of the identified risk factors of physical frailty includes increasing age, increasing number of comorbidities, polypharmacy, sarcopenia, depressive symptoms, cognitive disorders, lower educational level, lower physical activity levels, malnutrition, lack of social support. The identified risk factors for older Malaysian includes being female, having abdominal obesity, lower peak respiratory flow rate score, indicating lower endurance, and lower gait speed. It's noteworthy that physical frailty is also a predictor of the other physical frailty syndromes. Physical frailty screening is feasible at the community-based settings, and from our experience, Fright's criteria is doable, which includes measures of physiological deficits across 5 domains, which includes shrinking, measured using subjective report of unintentional weight loss of more than 5 kgs in prior year, slowness, measured using 5-meter walking speed, weakness, measured using hand grip strength, poor endurance, assessed using self-reporting exhaustion, and low physical activity, assessed using physical activity questionnaire. There are also other physical frailty screening that can be used in the primary healthcare settings or the community settings, for example, clinical frailty scale. Note that there are no gold standards for frailty screening. There are also no physiotherapist clinical guidelines for management of physical frailty. However, best available evidence can be used based on the systematic review findings. Current evidence-based practice for physical frailty management includes physical exercises, mainly multi-component exercises, health education, nutritional intervention, home visits, hormonal supplements, and cognitive training. Most effective interventions to delay or reverse physical frailty consist of multi-component exercises, cognitive training, nutritional intervention, and psychosocial support. These interventions can be combined into a multi-domain intervention for best and effective reversal of physical frailty. But exercise should be considered as the leading treatment strategy to prevent functional and cognitive decline in older persons. A common mistake in training with older person is to consider older person need to exercise moderately or take it easy. Although this may be true when starting an exercise program or in presence of comorbidities such as heart disease, balance disorders, and other comorbidities, but we know that healthy older persons respond to training in a manner similar to younger individuals. There are challenges for exercises, but still exercise is mandatory and should be mandatory to reverse physical frailty. Tailored exercise interventions in terms of frequency, intensity, type, and amount in time should be developed with consultation and guidance of physiotherapists. These exercises must be based on not only on functional status of the individuals, but also need to take into consideration falls risk, comorbidities, musculoskeletal pain, nutritional and cognitive statuses of the older person. As for evidence-based recommendations of exercise prescription, less than 2 times per week would likely not improve physical function, and more than 3 times per week could cause overtraining and loss of interest in some older persons. Nutritional interventions has also been shown to reverse physical frailty, and for this it's best to consult dietitians. Cognitive and physical function are the essence of functional status, and evidence have shown cognitive training to improve physical function, especially gait speed and balance. Exercises can be combined with cognitive training in activities like multitasking activities and also Tai Chi. Pen and paper activities that work on specific domains of cognition are suitable. Here is an example of multitask training, which is also beneficial for prevention of falls. Maintenance of exercise in older person is often difficult and requires continuous motivation and supervision. Tailored exercise programs at community-based settings should also consider behavioral aspects to ensure adherence and enhance self-efficacy. Boosting psychosocial and environmental support is vital. Group activities are highly recommended. So what can we do in situations such as lockdowns during the COVID-19 pandemic? Please do attend virtual programs, as we are confident it is possible with older persons from our recent experience. Key factors to improve participation and adherence includes notifications or reminders to older person about the program, having a supportive family or involvement of family in the program, providing adaptable exercise or programs in activities of daily living so that older persons can enjoy the benefits in daily life. The sessions should be enjoyable and fun. It can be conducted in small group therapy, and a trained facilitator is utmost important. Recently, we have conducted a multi-domain intervention in the community setting to reverse cognitive frailty among older persons, and we found this intervention to be even beneficial for older persons physically and psychosocially during the first COVID-19 movement control order in Malaysia. So what's the take-home message from this presentation? Physical frailty and pre-frailty is common in community-dwelling older persons, but it is preventable. Early screenings and assessments are important at community or at primary care settings. Older persons with frailty are at risk of other diseases and related decline in functional capacity. Knowing that evidence-based exercise works for physical frailty It is unethical not to prescribe evidence-based exercise programs for older persons with frailty in all community and care settings. And finally, to reverse frailty, a multi-domain approach is required and is best. In conclusion, prolong robustness, prevent decline, reverse frailty, and aim for resilience in older people. Thank you.
Assalamualaikum and a very good day. The topic that given to me today is COVID-19 and social isolation. I'm Dr. Asrini Abdul Razak from USM. I'm a consultant psychiatry. This is the one that we're going to discuss. The social isolation as a contact, the impact of COVID-19 on elderly mental health, and how to tackle the social isolation in pandemic and way forward. In general, most older adults have good mental health. However, they experience an increased frequency of life events that are losses rather than gains. Most of them have poor physical health. Not all, but majority, and this put them at risk for mental disorders. These are the common changes that elderly face. They have physical, mental, and social challenges. Some will actually face financial burden. The life experience, the life event that are lost rather than gain, especially the death of their spouse, the death of their friends, put them at risk to have some emotional disturbances. They face disability because the functional and the physical decline. Some will actually face the cognitive decline as in dementia. So they also face loss of social function. So these are the common emotional changes that elderly might face. Some will face denial, guilt, loneliness. Loneliness is the topic that we're going to discuss in relation to the social isolation. Sense of helplessness, extreme critical and suspicious behavior. Some would call it as paranoia. They become stubborn. They have problems with their memory. They have selective memory. They would act as a childish behavior that they regress. Some of them would love to talk about their past. Some of the carer would actually complain about this. But this is actually their memory that actually they have. Some will actually become so sensitive, anger, rage. Depression and anxiety is also not uncommon. And they have a lot of grief. So when we talk about social isolation in this context, especially during pandemic, the social isolation as it is being defined, an objective state marked by few or infrequent social contact is about the social networking. Loneliness is the subjective or distressing feeling of the social isolation and often defined as discrepancy between the actual and desired level of social connection. Some would say that loneliness can happen without social isolation. Okay? So when we look into loneliness research, it also poses a new global health epidemic with serious implication. And even so, with pandemic, the social isolation put this elderly into loneliness. It was expected that 25% of world population experience loneliness. However, the recent study in Malaysia found that social isolation or loneliness among elderly range between 36% to 53.4%, meaning that almost half of elderly experience loneliness. And the risk factors, including the age factor, the longer you live, the older you are, you face more loneliness. If you have no education, being female, widowed, no income, being challenged by the physical health, physical limitation, change of the family structure, family numbers of family shrinking, no longer living in extended family, loss of social support, living in urban, and lack of social security and lack of social activity has all been associated with loneliness. Now we're going to look into social isolation as a context, the focus of today's discussion. We can actually look into social isolation through two theories, sociological theory. One is actually social capital theory. It's about networks, organizational membership, and also generalized trust. Bourdieu actually said that social capital is a range of resources that are available to people through their social network contacts. However, Putman actually would actually talk about the features of the social organization, such as trust, the cohesiveness of the community member, the network that improve the situation of the community. And then this is what he wrote in the Bowling Alone, the collapse and revival of American community. So perhaps this context actually can explain why social health isolation is happened even prior to the pandemic. Another theory that can be used is structuration theory by Giddens. This is more about the agency and the structural context that shape the human behavior. So it is thought that social isolation is isolation of conventional, predictable pattern whereby some pattern did not fit any longer with those others. It's more on self rather than the structural context in terms of what Putnam tried to say, how the society, the surrounding actually can shape this social networking and how it can help to reduce social isolation. So when we talk about social isolation, it comes with implication. Okay, it actually can cause poor mental health, worsen the physical health because it is taught through the regulation of the dysregulation of the HPA axis, hypothalamic pituitary adrenal axis. It also can shorten the lifespan. It can increase into maladaptive coping mechanism, a lot of what we call smoking habit, sedentary lifestyle, okay, obesity, and also can actually cause stress, mediated production of cortisol, norepinephrine, beta endorphin, glucagon, and growth hormone that lead to the haywire of the metabolic. So it can cause increased blood glucose and insulin resistance. So it actually put elderly in social isolation into more health issues. And then such as hypertension, IHD, cerebrovascular accident, and motor decline. And also, it caused a lot of mental health issues, such as depression, anxiety, cognitive problem. So these are the data from our local study. NIPMAT actually doing study among elderly that actually in the nursing home. And then when we look into the data from suicide registry, Rahimi et al. Found that there is social isolation connected with suicidal among elderly in Malaysia. And then in a longitudinal study in Illinois, found that a synergistic symptomatology between loneliness and depression. So when we look into how COVID-19, this is the theoretical framework that we can actually can understand how social isolation related to COVID-19. COVID-19 not only caused physical health but also can cause psychological distress. And then when it causes psychological distress, it actually haywire all the body system plus the life event. As we actually observe nowadays, the death among elderly is actually mounting. The death due to COVID-19 actually more common in elderly compared to other ages. Okay, and then this actually cause issue with their subjective well-being. And then because the MCO, because of the standard operating procedure, SOP, they feel more disconnected. And then they perceive more social distance. And then this actually could jeopardize again their well-being, either physical or mental. So why? Why this is happening? Because elderly are prone to get infection. Those infection can cause death for elderly. And then the survival rate is actually without vaccination is actually very low among elderly because of the comorbidities. And then COVID-19 itself caused social destruction. There is loss of regularity, loss of the routine. It affecting the health and well-being of the people. They affect the social security. People are now facing a lot of problem with the financial, lot of burden with everything. So MCO also lead to perceived abandonment. Some of the elderly who actually believe that their children no longer care for them because they couldn't, their children couldn't visit them, okay, because of MCO. And then these mental health challenges is very common. Fear, uncertainty. We face a lot of patients that actually fear to go out. The elderly that fear to go out because fear of COVID-19 infection. There is also because of the uncertainty. When this COVID-19 would go, this actually cause panicking, anxiety disorder. Some actually face depression, and not suicide is also not uncommon. So now COVID-19 Kodokushi. Kodokushi is the dying alone that actually that is actually become popular in Japan because they actually live alone, live independently, and the death is actually usually undetected until years or months they actually found the body. It is dying alone. Okay, but in COVID-19, dying alone is common in Malaysia. Like this pepper cutting, there is more than 3 cases that die alone, the elderly die alone at home. We are lucky because in Malaysia, we don't have the seasonal weather. If we have winter, definitely the death is undetected because the body is not smelled. It's only when we wait until summer then it start to have this false smell. But here, why we detect? Because of the bad smell from the neighbors. Okay. If from the picture, the firefighter has to actually break the doors, the gate, because they die alone. It is also common for lonely dying, especially in when they actually has the COVID-19. Okay, because no longer the family member unable to be with them, and then this also lead to grief process. Okay, this is actually the real picture of what is happening in my hospital. And then this process is not only affected the family member, but also the treating team. When the family member requests, can I see my mom for the last time? And then this is the one that dying alone and also lonely dying. Okay, so when we look into COVID-19, It's not just only behavioral coping, but the grief process is become more complicated. So some are actually experiencing these disturbances. As grief, by Kubler-Ross said that we have 5 stages of grief. There's shock and denial, anger phase, bargaining, depressed, until they can accept. The survivor can accept, or the family member can accept. But in pandemic, the family member, the loved one, is unable to mourn as usual. So they have to actually do the grief alone because of the social distancing. The mourning, the bereavement processes actually serve as social support to the loved one, the beloved one, or even to the elderly. Their friend actually died because of COVID-19. Now they are left to grieve alone. So this actually put them more on social isolation. What about prolonged lockdown? Actually put them more at risk to anxiety, depression, and suicide. Some were actually being neglected or perceived abandonment. Definitely this actually can reduce their quality of life. So how to tackle social isolation during pandemic? We need the social cohesion. We need people to come together, work together, regardless races, regardless ethnicity, regardless political stand. We need to have a good support mechanism. So another thing is actually to use all the technology, because the face-to-face is no longer feasible until we control the COVID-19. So we need to have all these technology like telehealth, telemedicine, to be well versed with social media, the apps, the Zoom, the Skype, everything. And then we need to teach this elder about this new technology. This is what happening in Kelantan when at first the Ministry of Health claimed that the take-up of our vaccination is low. But when they did the research, go to the ground, it is because the elders in Kelantan doesn't know how to use MySejahtera. They don't even have access to the smartphone. So this is the issue. Perhaps we need to support the elder. So we need the community-based networking or resources. And then recently, we have this raise the white flag, meaning that be consider others. If you have in trouble, just raise the white flag so we can go and help you. This is actually part of the social capital resources that Putman said, which is the trust, the networking, the cautiousness, the participation, and the volunteerism come together to help people that really being affected by this pandemic. So we have to mobilize all the resources within the family and extra outside the family. Another thing is for the elderly to keep active, physical and mentally. So we advise the elderly to maintain their routine, okay, as if they are going for their meeting. So they do their exercise, they look after their health with good nutrition. Mental health can be helped with regular prayers, meditation, mindfulness exercise. And one thing during pandemic is the psychological flexibility, because the uncertainty is real during pandemic. So we have to be flexible. We have to be psychological flexible. Don't think about what we cannot do, but just emphasize whatever you have, your capacity, your ability to do at that point. So rather than focusing to being taken away from you. This is my final slide, the way forward, how to help, and then how we can move from social isolation to social connectedness, even during pandemic. One is actually to raise awareness that social isolation is an issue, is an health issue. So we have to educate the public, we have to educate the medical personnel that help the people. Another one is actually digitalization of the elderly, meaning that we have to occupy the elderly with the technology. We have to teach this elderly the latest technology, the latest app, even how to buy food using Grab, is using Food Panda, because this actually would help that sense of cohesiveness, sense of being sane during pandemic. And then another one is actually more innovative technology for intervention, like for the helper to go and help, to just check, social worker to check this elder, how they are going, so we can prevent what we call dying alone or lonely dying. With that, I thank you.
Three, two, one.
Hello and good morning, everyone. Thank you to all the speaker, Prof. Ranisman, Prof. Devinder, and Prof. Asrini. Good morning again. Thank you for the excellent talk today. So after listening to about an hour talk, I think we all aware we've been dealing with this COVID pandemic for almost 2 years now, and we all know that the consequence, the complication of the COVID pandemic is very detrimental, and it's not only to the physical and also to mental health and mental consequence. So we have few questions already here. So the first question, I would like to address this question to Prof. Ragisman. In your talk just now, the first few slides, I'm actually quite puzzled with your data. Just would like to ask you, your data shows just now that the rate of depression and anxiety is very much lower in US compared to in Asian country. Basically, we are like 3 times higher than the US. What do you think is the reason behind that, Prof? Is there any possible reason or explanation behind that?
Did you hear me?
Yes, can, Prof.
What's the question again?
The data shows that the rate of the depression and anxiety is much more higher in Asian country compared to the US. It's like 3 times higher. What do you think is the reason behind that? Is there any possible explanation behind that?
So I would think that because in our society we have some more think about like very sensitive issue when we have a COVID-19 situation and we care for other people, and then we try to protect our family and friends. So that's why most of them are so worried, especially in the family members. So I think that maybe in Asian, I'm not sure that in Asian or Asian culture, but in Thailand, most of the people like to take care of our families and friends and the colleagues. So we try to talk to each other and ask what's going on, and show how we show our expression more emotional for caring for each other. So I think maybe it's the cultural background. Thank you.
Yeah, thank you. Another question for you, Prof. Ragisman. One of the method that Thailand approach to tackle this mental issue during this pandemic, which I think is very attractive, is this walk-in or knock the door program. So basically, how do you choose the community or the village that is suitable for this program? Is there any specific criteria?
For the community program, you mean for the
The walk-in, yeah, the walk-in or the one that you mentioned just now, the walk-in or the knock the door program just now.
Oh, okay.
How do you choose them? Yeah.
Because we have like a healthcare volunteers in the village, so these kind of people help our professional. So this can be the go to the each door program. So it will more effective than just calling or maybe just give them information. So this more effective, and we have the healthcare volunteer to help them.
So basically, this program is depending on the interaction between the healthcare at that community itself.
Actually, we have the healthcare volunteers all of country, over the country. So this kind of person is more I mean, like a more influent person that can take care of the, like a frontier person to take care of the other people.
Okay. Okay, thank you, Prof. Ragisman. Okay, next is we have a question to Prof. Devinder. One of the question, Prof, is they're asking, how strong is the evidence for cognitive training in reversing the frailty? What is your thought on this?
Thank you, Dr. Huda. Cognitive training on its own has not much evidence, but a combination of exercise and cognitive training has more evidence, and is, I would say, is fairly strong evidence.
Fairly strong evidence. Okay. Yeah, I agree with you. It must be a combination. Usually in geriatric, we can't walk along. We can't walk alone, right? It must be a teamwork. Okay.
True.
Another question from Dr. Ellen. Okay, this is something that I think we see this in day-to-day work experience lah. Okay. How to change the mentality of the culture of our elderly? Tak payahlah makcik dah tua. Or no need to do. I'm old already. It's my time already. So I don't have to do exercise. Let it be. So how to change that culture? I think this is mainly a Malaysian culture, or is it an Asian culture? How to change this? What do you think?
It's really difficult to get older people to exercise, but once you start them on a routine exercise, or you get them to come to certain activities, maybe you structure some activities, some programs, they will stick to it. If you look at the adherence rate of exercises among older people, especially in Malaysia, I've seen, like, we've got very few dropouts. If you put it in a group, it's even better. They will come because they have this activity together. They have peers who encourage them. So I think it's how we package it. Of course, it's hard to get them to buy in, but once they are in, they will stay. That is for sure.
Yeah.
And recently, we also heard that a lot of older people would like to come into exercise program, especially after this COVID in overseas. They really want to do something because they know that activity and exercise can prevent a lot of diseases, including COVID-19. There is evidence that if you have increased physical activity, or you have more physical activity, you are less vulnerable, or you recover faster.
Yeah, agree. So in the meantime, Prof, while waiting for all this COVID to subside and to settle down, definitely all this group activity is still limited. What is your thought on this? Some of the patient, we are still allowed to do this sort of brisk walking every day. Do you think it's good enough for elderly for this sort of brisk walking at the moment? And if it is okay, what is the duration? And what is the frequency that is good enough at least to maintain them in a good state of physical health?
Thank you, Dr. Huda. Yes, we still encourage older people to exercise during these lockdowns. We've got lots of videos, we've got lots of guidelines coming out. We've got online activities as well. I know a few of our researchers have gone virtual. They have tried exercises online and older people actually join. Quite a number of people think that they can't do it, but with a little bit of technical help from the researcher or the provider or the caregiver, they are able to come online to exercise, and encouraging them to do something rather than nothing is still good. If you look at the recommendations, something is still than nothing. So if they can walk, that is good. We request them to walk around the home about 120 to 150 minutes per week will be good. So if you can tell them to do about 30 minutes per day will be good. This can be combined with other activities like sit to stand, standing on one leg, doing balance exercises, doing some gardening, doing some housework. All this is going to be very, very helpful as well.
Okay. Thank you, Prof. Devinder. It's such a good advice. So the last question, I think this is for Prof. Asrini. Such an excellent talk, Prof. Asrini, about the COVID-19 isolation, but at the same time, it's very sad with all the data, COVID-19, Kodakushi and everything. So I just would like you to ask you, what is your personal experience at this point in managing all these, I would say, is it a post-traumatic disorder or any extreme grieving or grieving alone so far? And from your experience, do you need to start any of this patient on any pharmacological therapy? Or at the moment, is it enough with non-pharmacological intervention alone?
Okay, thank you, Dr. Huda. The question is very valid, and then as what Prof. Raziman also shared, we in Malaysia has seen increased numbers of cases among elderly who actually face anxiety and depression. And the presentation kind of quite unique. I have one case presented with more on conversion, but when we assess further, it's actually anxiety or panic. And then these actually occur especially related to hearing news about the death of the one that their colleagues, okay? And if even the death about other people. So it actually induces anxiety kind of that thing, apart from the grief process itself. In general, grieving needs time, and then they don't need any medication, but more on supportive measures. So from our team, we have the psychological first aid, what we call, that support those who being affected by COVID, either being quarantined due to COVID-19 or being positive with COVID-19. So we do give the support, psychological support, call them using teleconsultation or telecounseling, so to elicit any needs they need. Actually, they just want a person to listen to their distress, and then we teach them some skill like relaxation skill, breathing technique, kind of that thing. But we know the grief process takes times, and then it needs more than one person to help. So the society, the surrounding should help. I mean,
especially if the person in being quarantined because of the COVID-19. So the interaction is limited. So this is the usage of social media or even teleconsultant, counseling helpful in reducing the impact of COVID-19 in terms of dealing with traumatic experience. We yet to see PTSD kind of symptom, post-traumatic stress disorder, just because I think the COVID is still ongoing, and then more on anxiety, acute response to it, more on grief response, not only to elderly but to all family member and also to the treating team. We have to do kind of support to the treating doctor, to those in frontliner, and also to the patient and those in quarantine. So basically, when they need medication is when they fulfill the clinical criteria for depression, and then it actually cause a bit danger to self or dangers to others, meaning that they have developed psychosis, they've developed suicidal. That is the point that medication is really needed in these cases.
Thank you, Prof. Aswini, for such a concise explanation. So I think overall we have such a good and concise talk for our breakout 2 session today. And as a take-home message, all of us agreed that it is important for us to aware about this mental health issue, especially with regard to this COVID-19 pandemic. And don't forget about this mental health issue with regard to our team, our staff, not only to our patient and the community around us, so that we can help them the best that we can. And then at the end of the day, maintaining the positive attitude and building resilience is a way to help us to fight this together. So with that, I would like to thank all of the speakers for the excellent talk, and hope all of the participants enjoy the rest of the talk today and the next 2 days of the Congress. With that, thank you.